Desiree,
Hey.
Tammy.
Make use of that time for sure.
All right, okay, now then.
I would like someone to do a wide view shoulder on me
Excellent. Hey, Ms.
so I can see
Madison.
and feel what they're feeling for.
Okay, this man requests a Y view shoulder.
How did I know? I had a feeling.
His right shoulder, and this time we're just gonna have a perpendicular central ray, so you don't have to worry about putting the tube angle on there.
Oh.
Oh, by the way, what was your tube angle on that last shot?
20.
20 degrees?
Mm-hmm.
Okay. Some doctors are really particular
I'm gonna have you take a step to the left.
about their angulation.
There you go. This is moving funny.
Okay. All right, so this is positioning for a Y view shoulder.
I was about nervous when I went in there. I don't know if I want to. I was like scared of what.
Alright, what I'm gonna do is I'm gonna have you turn to your side. So this is gonna be such a shoulder. You can turn with your feet, like you can step.
See, there ain't nobody
I'm
else.
gonna have you keep going.
I know you're just like they're turned over and you just pick one.
Okay, and I'm gonna have you take a
It's
step
like
up.
playing
on the front.
magic.
There you go.
No, you don't see nothing. You just see the back of the white paper.
This is moving again.
Background.
Okay, this is a tall patient with long arms.
So where did the 20-degree angle come into play?
Oh, that was something we were doing earlier. That was the near method. Okay, this is just the straight on Y view shoulder. Okay. All right, so our central ray is going to go through the patient's scapula, true.
Scapula.
But in particular, there's a certain part, yes, there you go, medial border of the scapula.
Midway through. Midway.
Right there.
Exactly. Now, you can palpate, the top of the shoulder quite easily. You know, it's just right there.
Yeah.
The hard part is finding the inferior angle of the scapula.
That's why I was like, is this one
Okay,
right?
sir, I'm just going to feel for your bones here a little bit. Please let me know if this is uncomfortable or painful. Okay, right there goes the inferior angle of the scapula. So we want to be about halfway in between, which is going to be approximately where that seam is. Okay, there you go.
That was low.
Okay, so I'm going to move our board down just a little bit. There we go. Okay, now right here goes his humerus, and right there is that medial border, and those things are pretty well lined up. Now, sir, I'm going to see if I can feel for your coracoid process. Okay, if I can find the coracoid and the acromion, then those things are going to be they're going to be parallel to the image receptor, perpendicular to the central ray. And yeah, that actually, I think you're right. Okay, Ms. Madison, I apologize. I thought you had this thing mispositioned, but you don't. That looks right.
This right here? Or what, up high?
Mhm.
Okay, yeah. Okay.
Beep.
Oh, any breathing? What's the breathing?
Oh, yeah, for this, you definitely need to suspend respiration because you're going to have a whole lot of rib anatomy on there. So now the patient doesn't have to take in a deep breath. You know, just say, just say, hold your breath. You know, okay, sir, I need you to hold still and hold your breath. Beep. Okay, you can relax and breathe normally.
Just relax. You can relax, but you're good.
Relax as much as possible.
You thinner, you find that how do you say it?
Coracoid.
Whatever you say,
Coracoid.
and then 1 inch below, right?
That is correct.
Are we gonna have to know the
Coral?
Grashing?
Grache.
I've seen that one.
Why,
way more
yes,
than
you
neutral.
will. Okay,
Yeah,
I've
most
seen that one every single time I've done a shoulder.
of our clinical sites do the same routine these days. They do.
It's not cool.
Yeah, it's a
Neutral just
15.
turn.
Yeah,
It is.
it's a 15-degree oblique.
You know, like this, right?
So they're basically neutral, then they're at a, like,
Which
day
one?
turn.
Right shoulder?
Like, their body is
Or
gonna be.
left shoulder?
Yeah, with their arm open though, so it opens up this
Yeah.
space right there. Yeah.
Okay, so for this x-ray, we're going to be locating the patient's coracoid and then going about an inch distal. That should put us at about the level of the GH joint, the glenohumeral joint.
An inch below the coracoid. Inch below the coracoid.
Are we doing neutral or what are we doing?
Okay, we're going to do internal and external.
Okay, so internal, you put the palm, I mean the back of the hand against the hip, right?
That is true.
Alright, well you got it.
1 inch below.
Is that good?
Well, okay, what are we doing with this collimation?
Alright.
Aren't we supposed to
Is it okay if we do 14 by 17?
be for a shoulder x-ray?
Crosswise, right?
Okay, you could shoot a shoulder x-ray on a 14 by 17 with the collimator wide open.
Because we didn't change it.
You're guaranteed not to miss.
Right.
But that's not really best practice. What we would like to do, and I know everybody's got these nice DR plates, and they're all 14 by 17 or 17 by 17. It's like, you know, you've got a lot of real estate to work with there. But we need to be coning down to just the area of interest. Collimation is good for your patient because that helps cut down on their radiation dosage.
Laura.
Alara, exactly. Okay, now, where is that coracoid process? Right there it goes. Okay, ma'am, I'm going to get you to move over just a touch. Okay, there we go. Now, we can cone down some. See all this light we got out here? We can cone down. We want to make sure we include that humerus.
Don't you want the,
Clavicle. Ding, ding,
don't
ding.
you need the joint though, between the clavicle
The
and
SC joint?
Yeah.
Yes. Okay, on at least one of your images, you want to include the SC joint.
So wouldn't that include it, or does it still need to be
Oh
called
yeah, you've got half the manubrium on there, so you're good. Okay, now then, we need to do an external rotation. So how are we going to position for that?
Stay just like that, and then rotate your hand with your palm out as far as you can.
There you go. Okay, now if our first image looked good, this one probably will too.
Okay. You can relax.
All right, fabulous. Okay, now what was the next thing we're supposed to be doing? Are you okay, Ms. Hope?
My hair got pinched by the tape.
All right, we had our patient's hair taped to the image receptor. Sorry about that. We strive for 5. Don't forget to fill out your customer courtesy card on the way out.
Got my hair taped.
Okay, what's the next image?
I believe it is a transthoracic lateral humerus.
All right, now for our next trick, transthoracic shoulder.
So she's going to turn this way. You're going like this?
It depends on which shoulder it is that's hurting.
Which one you want? I don't care. All right.
Wait.
Left.
So if it, yes, left.
Right.
So just put your arm up like this.
All right, now, okay, for this, where's our central ray supposed to exit the patient?
Surgical.
At approximately the surgical neck, which, okay, you can't really palpate that. You're just going to have to kind of eyeball it.
Does this need to be in line with her shoulder?
Mm-hmm. Sure
This.
does. Yes.
Here?
You want, well, you know, we could do kind of the same thing again. Find her coracoid process and then go down from there just a little bit. Yeah, okay, yeah, there you go. Okay, that might be a little bit,
Too far?
well, we can, okay, you're going to be on there. That's going to work. Now we just need to take our tube down to match. Okay, we've got our image receptor well placed. Now we need our tube down some. There you go. Okay, now don't come down too far because we got to make sure we include, there you go. We want to make sure we include the acromion on there. You can come down some side to side because remember we were talking about how the humerus is only like 1 inch or 1.5 inches in diameter. It's not that big.
Like that? Does she need to step forward?
Maybe. Well, that might actually be instructive. Okay, Ms. Mia, if you wouldn't mind, step this way.
Thank you. Oh, go back just a little bit.
Oh, you're talking about like to center. I thought you wanted her to step out of the way so you could see how
No,
big
no,
your
no, no.
collimated field is.
That's why I was like, why do you want me to keep going?
Okay, come over here. Okay, look at the size of that collimated field.
First of all,
Okay, so we might have come out of detent during the proceedings. Okay, that field is a little bit on the wide side, don't you think? We can come down. And remember, you can look at those numbers. That tells you how wide your field is. So if that thing's like 5 inches wide, that's going to be plenty. Provided we're centered correctly.
There's no other anatomy that you need to get in this except for the...
The main thing is the shoulder joint. Okay, now when you're doing transthoracic humerus, that's a little different. For transthoracic humerus, you've got to include the elbow and the acromion. So it's got to all be on there. But for just the transthoracic shoulder, remember, we're still concentrating on that joint.
is that too small?
No, ma'am.
That is money.
That looks good. Okay, so let's put that patient back where they belong. Make sure they're nice and lateral as much as possible.
No breathing.
Exactly. They're going to need to suspend breathing. Now, okay, on transthoracic humerus and transthoracic shoulder, here's an opportunity to use a breathing technique. Now, I know we really hadn't talked about this much, but you might see this at clinics. Some technologists really like it, and it's pretty if it works. If you've got a patient that is able to hold still, then for this shot here, you can just tell the patient to just keep breathing normally. And what we're going to do is we're going to modify. You know how on your control panel, when you pull up your mass and it's got a time associated with that? Okay, well, if you raise that time, you extend the time that your exposure is going to be made, then the computer on our console and most of the ones in clinic, the computer will automatically back off the milliamperage. So you got low MA, long time. Mass is the same. So your image is still going to look good, but there's going to be a lot of motion artifact. In this case, that's a good thing. If the ribs are moving up and down during the course of your exposure,
You want to get those out of there.
they're going to be blurred and they're basically going to be invisible. And so all you'll be left with is the humerus and the shoulder joint that stayed still during the whole exposure. Does that make sense? Yeah. So but that's the kind of thing, if you're comfortable doing that, then go for it. But, that's kind of advanced stuff.
So it would be your left marker?
Yes, because it's her left shoulder that we're looking at. What kind of marker's on there?
Left.
Left? Okay, good. I couldn't see it from here. All right, very good. Thank you very much, ladies. Okay.
A Y view shoulder.
All right, excellent.
That was great. Model.
I'm looking forward to seeing that. Okay, so our next image is Y view shoulder.
So when do we do, like, with the angle versus out?
When the doctor orders it. And some doctors, that's like their routine. Like, for example, whenever I used to work for Dr. Whitehurst, for all of our Y-view shoulder x-rays, he wanted a 25-degree angle. And that was just like,
So it's just protocol.
that was our protocol.
Okay.
25-degree angle, unless he specifically said otherwise.
Okay.
All right, ma'am, I hear you have some pain in your right shoulder. All right, so I'm going to get you to put this part of your shoulder against that board there. Going to feel around for some bones on your back.
Hey, this is kind of cool. We're all wearing masks, so nobody can tell it's us on the video. So what do we think of this image?
We got to lower that a little bit.
Yes.
And where that should exit surgical neck?
Well, okay, it's probably going to wind up exiting, yeah, at or slightly below the surgical neck.
medial border, I
Yep.
think, is
Uh-huh.
parallel or perpendicular.
And you want the CR in the midway. of
Okay,
the
ma'am, I'm
medial
gonna feel for
border.
some of your bones here.
Yeah.
I apologize for all this. Okay, so here's the top of our shoulder, here's that inferior angle. We wanna be about halfway in between. I think you approximately are.
Okay.
Now, here goes the medial border of our scapula. That's, yeah, but except for we're in detent, so we don't wanna move the two. We wanna move the patient. Now, are we obliqued enough or too much?
You check to see
Little
if
too
the
much.
coracoid
Well, I
is
don't
parallel.
know.
Check
Hang
to
on a
see if the
second.
coracoid's parallel.
Yeah, that's what I'm thinking too. Okay, hopefully this is not hurting you too bad. Sorry.
Massage.
Okay, yeah, I'm not trying to give you a back rub. I just want to feel for the acromion and the coracoid, and those feel pretty perpendicular, I think.
Okay.
So, okay, now our patient's obliquity is good, I'm thinking,
Okay.
but except for they're off center of the image
Right,
receptor.
so we want
just,
that there.
yes, we just need to get that patient to take a little shuffle step forward.
Yes.
Or, yeah, towards, away from us. Oopsie. Okay, she didn't move her feet, she just turned her body. Okay, there we go. That's a little bit
You need to
better.
adjust
That
the
is a little bit
bucky.
better.
Adjust the
Other
bucky.
than that, the rest of them.
Yeah, we definitely do. We need to come up some with the bucky.
Those are like the two extremes.
Ta-da!
Well, bam.
Okay, and see there, okay, she's more obliqued than Ms. Cat was a few minutes ago.
Right.
Because what you have to do, you know, there's no such thing as saying, okay, well, for a Y-view shoulder, I'm gonna always turn my patient exactly 40 degrees, or 45 degrees, or whatever. It's always gonna be a different angulation based on your patient's anatomy. You just have to feel for that, border, and then for the humerus, or the acromion, which is like right on top of the humerus, and then turn the patient so that those are lined up. Excellent.
Is this what you're feeling for right here?
This bone right here, you feel that?
Border patrol.
Okay.
So what do we think? Is it ready to be shot?
I think so. Let's just, you know, provide, okay, I think our patient's moving around. Sorry.
That's like.
I think she's, yeah, I think we need to turn back this way just a touch. That's more like what we had before.
But now we need her to take a little baby step forward.
Yes.
There we go.
Okay, and we're gonna shoot this. Now, if we shoot this and the humerus is too far posterior, then what?
We have to do a retake.
We need to do a retake. We're gonna have to take some of the obliquity off the patient, move them more into a lateral type position.
Yeah.
Now, if we shoot this and the humeral head is too far forward, then that means we had them twisted too far this way. Whoa, you okay? Okay, if we have them twisted too far this way, then the humerus is going to be in front of the scapula, and it's also going to be superimposing the ribs way more than it should. So then we know that we need to turn the patient this way a little bit.
You said
Now,
it would look how if it's too far out? The humerus?
I've got a picture in the over there in the radiographic critique book. Let's take a look. I got a girl named Boney Maroney. Okay, so here's our setup. Okay, so if this thing is accurately positioned, we've got the humerus up against the image receptor, and the scapula, the medial border of the scapula, is also going to be lined up with the humerus. Now, if the patient is turned too far towards the image receptor, that humerus is going to swing out, and it's going to be away from the rib cage, and we don't any longer see the scapula in profile. Okay, that's not good. We've got to reposition. So if that humerus is too far out, then we've got to rotate it so that it comes back in. If the patient is too oblique, they're moved in more of a lateral type position, then the humerus is not going to be lined up with the medial border. Now it's too far anterior. So we need to swing our patient back this way so that they're lined up.
So
And once you take your image, you'll be able to see how they're mispositioned, and then you can go back in and say, oh, sir, we got to do that one more time. I just need to get you to turn this way a little bit more. Okay, there you go. Hold that pose for me.
So ideally, you'd want the scapula on end so that it's, or the medial border on end so it's perfectly in profile.
Correct.
Okay.
And when you do that, you're going to see like a quarter or maybe a third of an inch of space in between the lateral rib margins and the scapula. There should be a gap in there. This is a hard shot. This is not easy stuff, and it takes a lot of practice to get good at this. I've been doing this for like 16 years, and I still miss about half the time. I mean, you know, not that I'm like the deity of X-ray or anything like that.
I have a quick question. Are any of you good note takers? 'Cause I was not here on Monday.
I'm an outstanding note taker. What do you need?
So we went over the PowerPoints of Unit 5. Yeah.
Pretty much it.
Oh, okay. You're wanting to borrow somebody's notes?
Yeah. I was
Oh, okay.
I was in the hospital.
Oh.
You're feeling better now, though?
Yep.
All right, that's good.
You can try to read mine, but like I have the worst handwriting in the entire world.
I just print out like the slideshow and kind of like add a few extra notes.
That's what I do.
Basically it.
All right, Miss Sandra, let's see your stuff. By the way, what are we doing here?
I want to try the Y shoulder.
Y-view shoulder. Okay, excellent. This patient needs a Y-view shoulder and some bigger gloves.
I'm good with smalls. This is from my sister. Okay, why view shoulder?
I mean, I can send you the notes if you want.
I guess we're
I
going to
don't
do
have
this
them
one.
with me, but you remember.
Okay.
All right, no.
No deal.
Yeah.
If you have questions about
Right
what
shoulder is
somebody
fine.
says,
Am I supposed to palpate that,
Yes, that would be very helpful.
see the radial head up here?
Don't worry about this column.
And then find,
Okay, if her radial head is in her shoulder, then we got a big issue.
Just a whole bunch of.
I thought you were like,
Humeral head.
The humeral head.
yeah, that's what I. Lord have mercy.
It's okay.
So is that it there?
Okay, that right there, that bony outcropping, protuberance, that's her acromion. So yeah, that's going to be approximately in line with the top of the humerus. So
Okay.
that's, you can use that for a palpable landmark. Or you can just kind of eyeball where her humerus is.
Oh,
Oh,
sorry.
no, it's my fault.
Man, who the heck jacked that thing up? That thing's jacked up there.
I had to get it out of the way.
Goodness
Oh.
gracious.
I was making a demonstration. Okay, we're going to line up with the medial border of the scapula, about halfway down. And you want your medial border and your acromion
So it
and...
needs to be lined up with the scapula right here. Right?
Yes, ma'am.
Midway. Midway on my medial. That's it.
Yes, the medial of the medial.
Yep.
You step over a little bit, I'm sure it's still lined up. Yeah, it is. All right. Sorry, I'm moving you all around.
Oh, that's all right.
I've seen my coworkers positioning patients, and they had them like almost facing the board. And I'm thinking to myself, that'll never work. You know, they're going to miss. And then they take the exposure, and it's perfect.
I did a couple times like with the posture, and they're like right, but then they have like too good a posture,
Uh-huh.
you know, because like some people are so
So how's this look?
That actually looks pretty good, I'm thinking. Tubular?
Yeah.
Okay, right there is. All right, you probably need to come, probably should come up just a little bit. I mean, you're definitely going to get all the scapula on this. But right here goes her inferior angle, and this top of the shoulder, so I don't know.
So it needs to be
You're
like kind of
probably-
in between that?
Actually, you're probably good right there. If this patient would quit bobbing and weaving. Okay,
So
I don't know, I think that looks good.
it needs to be between the inferior angle and the top of the...
Yes, what you want to do, what you're trying to do is aim basically for the midpoint of this scapula. So if you find the inferior angle and then the top of their shoulder, then you know it's going to be like halfway in between. And you're about there.
Feel better
That's
there?
good.
I don't know.
Good. Okay, good.
There.
Yeah,
How do you like that? What do you think, Ms. Madison?
Yeah.
I think so too. All right, marker, shield, and shoot.
Now she's...
And you can definitely cone in side to side on this one, because see how you got all that light out there on the patient's right? So just cone in a little more, bring it into skin line.
There?
Yeah, you can actually cone in, touch more, because see, you got plenty of light out there. All right. Miss Pridgeon is not wanting to cone down, but that's okay.
You should just do it where the light just goes away. Is that good for you?
So like that.
How about now?
Yeah, I think that's good. And see, you got that big area of light out there that you can put your marker on. Okay, very good. Y-view shoulder. You guys are just going to have to practice this. That's the only way to get good at it is just to do it. So every time somebody comes in with a shoulder X-ray, grab it.
Jen.
Just want to stay okay.
All right, so we got a couple of first timers today.
Are we still doing one?
It's up to you. What do you want to practice on, Miss Catherine?
Just make easier to video.
Yeah, I'm practicing on why, because
Okay, cool.
it's difficult. I've seen it.
Oh,
in
I just
clinic.
assumed you were going on one, my bad.
Yeah, no worries. Okay, let me picture this.
10 o'clock.
Close to the floor.
What's happening at 10 o'clock?
Oh, nothing.
It is 10 o'clock,
Oh, it is 10 o'clock.
so this is what's happening at 10 o'clock.
Okay, so
Me, I'm what's happening.
line it up here.
Okay, can you feel the inferior inferior angle of her scapula?
Yes.
Just don't be shy. Dig right in there.
All right.
I think all sorts of noises. It's just, I don't know.
We've noticed.
Oh.
You're really taking them all.
Hang on a sec. Let me move this out the way. So I can come over there. All right, Ms. Pridgeon. I apologize for all this, but I'm afraid I'm going to have to find some bones on your back. Okay, right there. Okay, you need to get really good at finding the inferior angle of the scapula, not just for shoulder x-rays, but also for chest x-rays. If you can find that inferior angle and then you go up from that just a teeny bit, then you're going to be like dead center on your chest x-rays every time. Okay, cool. So what we got here, yeah, okay, height-wise, I think you're good. Now, let's find her shoulder. Okay, right there goes the acromion. You feel it? Feel that bone sticking up there?
Was it this?
It's this.
This, okay.
Yeah, I had a hard time with that too.
Yeah. Okay, find that, and then find that medial border, and then line those up so that they're perpendicular to the image receptor.
So this.
Mm-hmm. And you can ask your patient, okay, ma'am, I need you to, there you go. Ask your patient to turn if you need them to. Ask them to take shuffle step forward or backwards. Now, some of our patients, it's like you tell them to step forward and they just stand there. They don't move.
The geriatrics do that.
All right, we're going to bring this up so that it matches. All right, and we've included that poke. We've included that angle. Sorry. And we've included the top of the shoulder. Okay, so we've got everything on there we need. Collimation is good. This here is her right, so we're just going to mark it just like that. Okay, and your central ray is pretty much through that medial border. And it looks like to me, Ms. Madison, you're in the good position back there. Can you see? Okay, like right here goes her medial border, and right here is her acromion. Am I basically lined up, or do I need to be turned more or less?
No, she's turned good, but she just needs to like move up just a little bit.
Okay, ma'am, can you take a little shuffle step forward?
Like that. Well,
Okay, now,
Too far?
like the angle is good. Yeah, that was good.
okay,
Yeah.
how's that?
Yeah. Yeah,
All right.
that's good.
All right, super. Ms. Madison is my scapular Y expert.
I also don't know if you got any of them. Because I think you guys were both blocking her.
Oh, gosh. Okay.
Because when I
think
came
you're
over for a
good
second
now.
ago to look, and then I was going to move it. You asked me to just look at that.
Oh, well.
Just from when I started.
Get you over here. Oh wait, we're gonna do a tabletop, right?
This is, okay, it depends on what your patient can do. And it just so happens, I'm sorry, Ms. Berger, go ahead.
No. I can't read now.
He can't do much, so.
He can
But I
move,
mean, you should be able to.
he can
like-
move this. That's all he can do.
Okay.
That's all he can do. I gave you a sponge over there that you're gonna use, and that's all. You see what I'm trying to do? Basically.
So that's all I can do.
This,
So
like
then
this, Mr. Lake.
Mm-hmm.
the lateral,
Sponge.
when you go to the side.
That's, you see what I'm doing now?
I do.
To the sponge.
Tracheal. Tracheal. All right.
This is the sponge you're gonna be using.
Can be a team effort.
Watch
We need
his broken arm.
Okay.
Oh my god.
Glimpse down at it.
All right. I'm gonna need some team members here. Because it can be a team effort.
We need
Well,
to
try her
take,
and do it, because in clinic you might have to do it by yourself for a comp, so.
Okay.
But
So.
like they can help you, but it should be the tech.
Okay. All right. Now, so what we agree to use?
What, actually, I did say it was team effort, so what would y'all do? You wanna help?
Just try to. So we're doing PA first.
Not sure.
what can I do? This?
You can rotate at your shoulder,
Okay.
So he can get.
So like this?
yes. You can rotate at your shoulder, and at your
Can I
wrist.
lift my arm?
You can
Like
do
this?
it like
A little bit?
You're
Okay.
gonna want to.
Okay. So can you just rest your arm this way?
Oh! Oh!
So do one of those.
My arm.
Like I'm gonna
Do a bit of an angle.
You could raise the table a little bit.
This
More
way.
comfortable.
Do you think that we're gonna have, like, are you trying to do the PA or you're trying to do the, well, like, which one are you doing?
Well, so getting his wrist and yeah, the PA.
So do you think that's gonna be a good image?
If I could get this, if I could get.
Can he lay that?
But think about the image
Could you
for
not
second.
like?
Like,
You're
He
on
can't
the
be
shoe
level
and
with
it's
the
gonna be
wall.
down there.
So,
So he needs to hold the
Oh,
except with
right.
the other hand or something.
yeah, so.
Yeah, well, I need some help then. I don't know what I'm doing.
So like, so taking his arm and So will you place your arm again? And then something like, and so he's able to do this. So you do this and you can relax your elbow very gently. And then now you can put the cassette under here.
Okay,
And there you go.
so how do I keep this in place? Tape?
I can, the weight of my arm.
I was, yeah, or your patient's other arm is not injured, so he could maybe help out with that.
Okay.
Yeah, I'll leave.
But you're gonna get some magnification here.
So what can you do to fix that?
With this block? Not
Or you-
very much.
Or you can do something else. So what could you do?
Oh, and
But very gently, because he's broken, like and then you can just stick another sponge, you could stick a washcloth, he could hold it, but, you could do whatever.
Okay.
So you-
Is that the key?
whatever, fine.
Excellent.
Because usually if you go, he can do this, but very slowly, and then you can get it, and then he's not too great. There you go. Oh, that's perfect. So now, what are you gonna do? Does everybody see, like, why that is gonna work?
Okay, let me borrow this 14 vial from under you.
Sorry, sir,
We
you
don't really need that.
So like this is critical thinking, and this is a trauma upper extremity where you have to kind of see what their limitations, and then you can tweak it from there.
And at some point in time, y'all are going to need to get trauma comps, specifically trauma comps. And this is the kind of thing that counts.
Well, this is actually, they just took the test, so this is, they can do it.
Oh, yeah, that's right. If they had a trauma wrist, they could go ahead and do it.
Yep, that is why I want to make sure they can do it. So now, what do you think?
You need an angle.
Yeah.
Yeah.
So instead of,
Here you go. What did you follow me?
we should come
Here.
down here.
Well, I don't want to knock Ben out. See?
There you go. Pivot the tube.
I mean, and y'all are thinking, oh my gosh, but like, you're gonna see this, but you're gonna be able to apply it in clinic, because this is a trauma. This is what you could do for a trauma. It could be a trauma hand, a trauma wrist, a trauma forearm. And for trauma, you know, we're not gonna be so worried about getting the part of
Wait,
interest
this
in
is
the
the
middle
wrist,
image
right?
receptor.
Yes, ma'am. Okay, so this first image is going to be for our PA wrist. And so we've got the tube angled to match the image receptor.
And like I said, like, it would be ideal to have it all matching up, but as long as it's on the image receptor and we got everything we need, there we go.
So how can you ensure that this is the right angle?
It's just like a chest,
you
it's
want-
perception.
yeah.
It's just
You
perception.
just want parking.
And it basically,
it is.
if you stand over here and look, I mean, it might not be exactly, but it's pretty close.
Yep. So that's gonna achieve a PA wrist, and so the doctor will be able to see what he needs to see. So now, that doctor, remember, he's Mr. Fickle. He wants
The 3 views.
the 3 views.
Okay.
So what could we do next?
Okay, now we need to oblique that wrist, right?
So we need a sponge.
But he can't rotate.
Oh, we can't rotate. Okay, so,
You could angle the tube
Yes.
yeah.
So now, which way would we go?
from this side.
Sorry about that, sir.
We're just checking if you're really injured or not.
Anybody else want to do it?
So what do you think? Which way would we go?
I would do like 45-degree angle coming from that way towards his wrist.
So I'm going that way.
Yes.
Yes.
So I can bring that back.
Okay, ordinarily.
Would you not go this way because of him sitting there? Right.
Okay, I'm puzzling this out in my head.
Oh, you are
Check it out. Yes. Okay, if this is my oblique position normally, and the tube's pointing straight down. Now, if I turn my hand this way, and the tube's going to track with me, now it's over here.
Right.
See?
And you gotta change the IR as
So
well.
what I was saying is, you wouldn't come, like, you
Yes.
wouldn't have the tube
Because
going
if it
opposite way.
was, if it was a CR cassette, you would
Correct.
change it out.
Yeah.
But do you, but now, critically thinking, think about what I gave a lot of feedback today about the coil method and that carpal tunnel. You would, when you change out the cassette, where do you want to make sure that this part of interest is?
Lengthwise.
Yes, but also way over here,
Oh, right.
because it's going to get thrown, the angle's going to throw it way over here.
Yep. This whole thing is going to be elongated, but it should be, the doctor should still be able to see what he needs to.
Yep, because it will separate the bones and separate the fractures. All right. So then, this would be where I would probably put the marker like way up at the top or something, because.
So,
50 inches. So that means we need to add about 25% to our technique.
Yep, and so if it's a trauma, you know, and he's hurting, I would just leave it and fix that. Because he's probably upset, he's, you know, whining, because if he can't do anything but this, he's probably really in pain. So you do have to be able to just kind of adjust and do critical thinking. So, but that is, like, you can put an angle on the tube for a wrist, for the elbow, for a knee, an ankle, a foot, all that is the same concept. A finger, if they needed to. It's the same concept, so your angle is going the same way as you would have licked them.
and so a lateral maybe, somehow,
now.
some way.
That's gonna.
What'd she say?
She's like, okay.
Because that's gonna have to go behind.
Yeah, luckily you guys have
Can't you just,
got,
like, take all this stuff away now?
Well, you still want them on the sponge though.
Yeah, because he can't extend it down.
Do we have like a flat sponge?
Yeah,
Like
I was
not
like-
angle.
Which one?
You can use any sponge.
Yeah.
any old sponge.
Okay, can you lift your arm for me, please?
Oh,
Alright.
Sponge might be a little bit.
Cause you... I don't know, could you do this and then do it like that?
You could just, so you could do,
Can you lift your arm one more
I mean,
time?
they're able to, yeah, I guess, right?
And then... Could you do that and then just put an angle going straight in?
so what else?
Can you move your arm any closer to this board for me? As far as you can. Alright, good.
So if it's a trauma, you usually help them, like guide them or support them. So
Okay.
now, what would happen if the patient, like I said, he can't do straight. He was just like, oh.
Like it can't go.
Oh, like if he was-
So now he would basically only be able to do that. So how would you get a lateral if you only could do, kind of like, he was still like, you know, propped up like, oh.
You would put an angle,
Angle,
on
yeah,
the
like a
tube.
slice.
And then put it like
Oh, wait,
that
so you
tube that way, right?
oh, that's better,
So,
doctor, that's
Yeah,
better.
you would do this thing.
You don't need an angle on the tube, you just move the collimator.
Oh, I see what you're saying, yeah,
just
yeah.
move the
Yeah.
collimator like that.
Kind of like we did with the humerus a while
Yeah.
ago, where you just line up with the bone. There you
So
go.
ideally, you know, if he could move his part of interest closer to the image receptor, would be less OID, so less magnification, less blur, better detail. But now, It's not gonna be perfectly in the middle of the image receptor, but it is a 90-degree relationship so the doctor can see.
All right, sir, we just got done processing your x-rays, and there's nothing wrong with your arm.
All right, sweet.
He's healed.
You got out of work just long enough, right?
Yeah. Pain just went
He'll
away.
look at you like, can you give me a work?
Can I get a letter for work?
So, like, you can see where you have to use critical thinking for those trauma comps. And so, like, that's where it is. Like, you use sponges, but make sure you stay within his constraints. Like, don't try to give him sponges that take him out of his comfort zone, because you don't want to hurt him as well. How about, what was the next one? Was it a
Elbow.
elbow? Ooh.
Are we supposed to be doing these with the portable? Or
You
no?
don't know.
Oh.
No, you don't have. I did it because I thought
Don't
that
necessarily
it was
have.
something
Okay.
else, another thing you could do. You don't have to use a portable. I was just giving you a way to
Yep.
position.
Because sometimes patients come in, and we can just bring them into the x-ray room.
Yep.